Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you, be able to answer any questions that you may have. There's a question and answer button on the right-hand side of your screen where you can type your questions at any time and we'll try to get them answered during the webinar. At the end of the webinar, you'll receive an email with a feedback survey. Once you complete that survey, an email with your CE certificate will be sent to you. So it's important to be on the lookout for that email shortly after we finish. Today, it's my honor to present or introduce our speaker, Dr. Michael A. Pikos. Dr. Pikos is a board-certified oral maxillofacial surgeon and summa cum laude and Phi Beta Kappa graduate of the Ohio State University. He's also the founder and CEO of the Pikos Institute. Since 1990, he has been teaching advanced bone and soft tissue grafting courses, along with full arch immediate reconstruction courses, with alumni that now numbers over 7,000 and is from all 50 states and 67 countries around the world. He has performed thousands of bone and soft tissue grafting procedures and has placed more than 35,000 implants. Dr. Pikos has lectured extensively on dental implants in the United States and internationally, and is a well-published author. His publications include his recent book, Bone Augmentation and Implant Dentistry. Dr. Pikos is the founder and CEO of Coastal Jaw Surgery. It's a 9-doctor multidisciplinary practice in Tampa Bay, Florida, and he limits his practice exclusively to implant surgical reconstruction. I've had a long relationship with Dr. Pikos, and very thankful that he's taking the time this evening to share with us some of his extensive knowledge when it comes to the areas of bone and soft tissue grafting. Once again, Dr. Pikos, thanks for being with us, and I'll turn it over to you.
Well, thank you, Russ. I very much appreciate the opportunity to be here, and would like to thank also Shelley and Shane for this opportunity. It's always a pleasure to be able to share some of my clinical experiences with my colleagues. So with that said, want to get started. We've got a fair amount of information here to share and slides to go over with you all. So want to just be able to just get started on time as best we can. This is a very interesting topic that I'll certainly be able to get into quite a bit of detail with all of you on. And it's one that I think is something that we all get involved with one way or another in our practices. I've been in practice now some 42 years and counting. Kind of hard to believe the time goes by so fast. And as Russ mentioned, we've got a great clinical team where 3 of us are oral surgeons, soon to be adding a 4th to the group. We also have 3 periodontists, 2 of which happen to be my kids. To my left shoulder is my daughter, Lindsay, and to her left is my son, Tony. And last but not least, we have a prosthodontist, Phil Hedger. So as you can see, a very interesting and unique multidisciplinary group of clinicians under one roof. We also have a tremendously talented lab technician, Luis Brito, who's a master ceramist from Brazil. And last but not least, we have an amazing anesthesia team headed by my wife, Diane, who actually is now formally retired as of April. But we now have a different younger group headed by Bobby, who's just been an outstanding addition to the team. So with that said, the Institute, as Russ mentioned, we're in our 36th year, have over 7,000 alumni, all 50 states and 67 countries. It's been a wonderful journey. I've enjoyed interfacing with so many wonderful clinicians over the years. Just a quick disclaimer, none of my images have been altered or manipulated. I think that's important in this digital age. And in other words, we're not growing bone and soft tissue at the push of a button. So I think that's really important to share with all of our audiences. Now, this particular topic, technically, we have one of 2 ways to go when we take teeth out, whether they're in the aesthetic zone or not. And yes, in fact, this particular discussion is limited to non-aesthetic zone socket grafting. But when we can place an implant immediately, we certainly do. And that's the primary motivation and indication that we'd like to have and be able to follow through with. But a number of our situations are such that we need to graft. So with that said, this is the outline I'd like to cover with you. We'll look at wound healing briefly and then zero in on clinical cases in both the mandible and the maxilla. So first things first, we extract a tooth, regardless of where it's in the mouth. If we do nothing to that site, what we're going to see within 24 hours is early formation of a fiber network that includes certainly platelets and becomes more or less a coagulum. Now, that said, that coagulum then really includes mesenchymal cells, certainly growth factors, and ultimately it becomes sterilized by the fact that we have neutrophils and macrophages that enter that wound site, along with growth factors. And by 2 to 4 days, that early, we, in the program here, in the workflow, if you will, the granulation tissue formation stage happens. So we're beginning to see that blood clot breaking down. And by 2 weeks, approximately, we then have young connective tissue that is very abundantly infused with blood vessels, inflammatory cells. We then have woven bone as the next stage, roughly 4 to 6 weeks out, followed by finally lamellar bone. And that's usually at the 4-month mark plus. And that original socket then is more or less deemed mature bone, quote unquote. Now, this particular citation I'd like to just share with you briefly. It's one that was published back in 2016 by Dr. Brian Mealy and his group in San Antonio. Very well done study. And what they did was they wanted to evaluate both histologically new bone formation and dimensional changes of grafting these different sockets with demineralized freeze-dried bone allograft. And they called the more or less the short group, short-term group, 8 to 10 weeks reentry versus long-term 18 to 20 weeks. And as one would expect, a significantly higher percent of new bone, vital bone formation was definitely found in the long-term group, 47% roughly to 32%. So bottom line is we wait roughly 4 months plus, then we're going to have new vital bone formation. This is now without any grafting into that site. So keep that in mind. Now, looking at some cases in the mandible in particular, posterior mandible, these are situations that we see all the time. Certainly extraction of the tooth is first order of business. Many ways to take out teeth. Time doesn't permit to get into any kind of real details other than I do like this little approximator that I'll share with you, a quick video. I have nothing to gain by, matter of fact, talk about any particular products or instrumentation. This is just more of an FYI. I found this to be a very valuable little instrument over the years now. Comes in different angulations, but in essence, really comes in handy for root tip removal in particular. So we have a typical situation like this, mandibular first molar, where we've got, of course, a failing tooth. You can see the periapical lesion, the widened periodontal ligament, etc. So first order of business, of course, is extraction of the tooth. We try to do this in a minimally traumatic fashion, sectioning, removing roots, etc. And then creating, back up here, creating what I'll term a pouch, a lingual and a buccal pouch. I do this with nothing more than a dental-alveolar curette. And what I'm doing is making room for this D-PTFE membrane, D standing for dense polytetrafluoroethylene. And this particular membrane is really made to be able to be exposed to the oral cavity. And for the last almost, 20 years roughly, I've been using this membrane. It's been nothing but amazing in terms of how it performs for this particular application. So in essence, we're placing this membrane after it's being trimmed in one pouch or the other, in this case, the lingual first, and then graft is introduced. My go-to graft for the past almost 25 years in general for all of my alveolar ridge grafts in particular is a mineralized irradiated allograft, cortical cancellous. Gradient is typically 0.6 to 1.2 millimeter particle size, and having done a gazillion of, or having obtained a gazillion specimens, if you will, over the years, the histology really has been very, very consistent, as you're going to see throughout this presentation, taking course at different time frames post-surgery. So once that graft is condensed, then that membrane is placed into the opposing pouch. And then, of course, suturing here, showing you PTFE suture, with a large FS2 needle. It's nothing more than a horizontal crisscross mattress suture that I'll go over in a little bit more detail here in just a bit. At 4 weeks, that's the time frame for reentry. And what do we have here but a very nice keratinized area of tissue? This is very consistent. I mean, case to case to case. And radiographically, this is also very predictable results in terms of what we see, which is an opacified area where the graft complex has pretty much been replaced 80-90% of it at this point in time by patient's own bone. This is just another one of my series of case studies that I show in my book on bone grafting. And the beauty at this point in time is we can not just place an implant, but we can actually load it if we preferred. Our torques are typically 40, 50, 60 Newton centimeters and up. And this is just nothing more than an 8-year follow-up showing good marginal bone stability in this grafted site. So a very typical case. But let's go through another one here where ideally we're placing these, we're grafting these sites in a flapless mode, meaning extracting ideally without making any I would say surface release incisions. In other words, if anything, we look at more of a cellular approach. Here we have a distal extension area, now just a terminal molar that's in trouble. So upon extraction, I will typically make a small release incision at the crest, and then cellular for more or less an envelope incision kind of design. I do like to decornate the tooth in general, and then remove roots accordingly, sectioning typically with an 8 or a 6 round burr, as you're seeing here. So no problem. And now important is to visually and tactily look at this socket and aggressively curettage, removing any granulation tissue, certainly any small root fragments, bone fragments, etc. And then creating this pouch, as I mentioned earlier, nothing more than a dental curette, and getting against, putting pressure against bone to create a true mucosal flap, in other words, full thickness. That's done on both the facial and buccal aspects, as you're seeing here, or I should say lingual. And then it's a matter of trimming. The most, I'd say, the member I use the most is a 12 by 24, as you're seeing here. And I'll talk more on a different dimension here in just a bit, but typically trimming the width only, and then introducing it nicely into the pouch, as you're seeing here. First one side, and then, of course, after grafting, the opposite side. Now, these membranes have a shiny side to them and a dull side. The goal here is to have that shiny side down. Ideally, I will say this, the first year I placed these membranes some years back, I did it back afterwards, and it still worked. So for what it's worth, these membranes are pretty versatile. So I'm introducing the graft, as you see here, and condensing it, I'd say moderate to firm condensation, and making sure that bone is only to the crest of the ridge, not over that. It will just basically extravasate if you do that. And then tucking the membrane to the opposite pouch, as you see here. And then a series of, suturing. This is nothing more than a crisscross mattress suture we talked about. Horizontal mattress where the suture is completely on the membrane, and thus allowing for some pressure. And then finally, 2 single interrupted sutures. So 3 sutures typically takes care of most all the extraction sites that I deal with like this. And then, as I mentioned, follow-up is typically 4 weeks, at which time I remove sutures and the membrane. And on the right image, as you're seeing, we're always at a 4-week mark seeing early granulation tissue, early reepithelialization. And by 4 months, that image is very, very predictable. We see good keratinized gingiva throughout the entire crest. Now, in the old days, so to speak, many years back, in order to more or less address the same kind of an extraction site defect, would graft it and then get primary closure by advancing the flap, making surface release incisions, and then having, of course, unattached tissue. We'd have to go back and do a V-plasty. That doesn't have to be done now for a number of years, thanks to these membranes. So this is a very typical core taken. Actually, I should say it's atypical in that that's a D1 core there is basically no marrow to speak of. This is unusual to see 95% vital bone with D1 presentation. The vital bone is common, but not D1. Typically, we see D2 at 4 months. But at any rate, here, excellent bone incorporation of the graft and a nice 10-year follow-up. So again, very typical, nothing, no rocket science here. This is probably the most predictable graft that we do in all of implant dentistry, in my humble opinion, meaning socket grafting and the way in which I'm presenting it as well. So moving along, where we have even further compromise to this tooth as it's failing, we have a buccal plate blowout. We see this commonly, certainly. And now we have different ways to approach this. I'm going to show you a more invasive approach that I really haven't used in probably 8-10 years. But it is one that where a release incision, surface release, could be made. And then a membrane like this could be placed. It's termed the buccal. And by the way, Osteogenics has a series of different membranes with and without titanium reinforcement that one can use for different applications, certainly. But for this one, using this particular buccal with two Profix screw fixations here at the base, and then tucking the membrane over the top. Once I've incorporated the graft complex with recombinant PDGA that I'll talk about here for just a minute. This is a very potent protein that is made, of course, lab-based, and hence recombinant name. The first recombinant protein of this type was actually FDA approved back in '97, and it was in more of a gel formulation for neuropathic dermal ulcers for diabetic patients. Now, 2005 is when it was FDA cleared for primarily periodontal regeneration application. At any rate, it's 1,000 times more concentrated than what we have in our blood. So with that said, this protein in particular attracts stem cells, and that's one of its biggest claims to fame, so to speak. It's a great feature that it has, great property. And here you see at 5 months, what I've done at the 1 month mark is I will have trimmed this membrane at the line angle that you're seeing on the buccal aspect. Notice I will have unfolded the membrane and just clipped it at 1 month. And then at 5 months, I can remove that membrane. But here I'm showing you very invasively, again, having to open up and remove screws and what have you. Not necessary. If in fact you use the surface release as I showed you to start and re-entered, and place the membrane with the graft, on re-entry, we could just do premucosal incisions and remove those screws. So not a big deal here at all. In other words, this case is so old that if I were doing it today, and in the past probably 7-8 years, I would do it in a more minimally invasive approach, meaning no surface release incisions, only envelope. So with that said, here's still another lower case that you see complete dehiscence of this root and a complete buccal plate blowout, as you see here on that left image. So these types of cases, especially if the lingual plate is compromised at all, I like to use the bazooka, as I call it, that is BMP. Is it absolutely critical to use it here, necessary? Well, if both plates are compromised, my answer is yes. And you see some decortication to get some good marrow penetration and blood supply increase. There's our BMP placed with some particulate grafting, membrane fixation. And here we are now some 7 months out. And as you can see in the right-hand image, the bone turnover is extremely predictable. For BMP, I typically wait 7 months. I do that for all of my ridge grafts. I've done now more than 500 BMP cases in the last 19, 20 years, and a very predictable way of grafting, certainly for even extraction sites like this. Not real common to use it for these sites, but when I have a compromised site, again, buccal plate and lingual, then that's when I typically go to BMP. Again, very predictable result, 8-year follow-ups. As you're seeing, I'm showing you minimum 5 and longer year follow-ups to really show proof of concept of how stable these grafted sites become ultimately. So now, that said, we're going to shift gears and go to the maxilla, where once again, I'll give you some insight with regard to how I handle these cases. the older way, if you will, as well as more recent, last, say, 7, 8, 10 years. A case like this, extraction site, there's a wall defect, certainly buccal plate, facial plate compromised. Doing this case today, I would not flap this at all. In other words, I would not make any surface release incisions. Would be just an envelope incision and be able to still graft the site and place this kind of membrane, which is titanium reinforced PTFE. That works quite well for this particular application. And again, closure. And ultimately, there's a 2-week follow-up just to see how tissue looks. Early on, I would have these patients come back at 2 weeks just for suture removal, and then 4 weeks for membrane removal. I will tell you that that's not necessary, that in essence, better to have the patient back at the 4-week mark and remove sutures and membrane. And then at the 4-month mark, implant could be placed. Follow-up CBCT, and 99+% of the time we have graft turnover very predictably. And here I just flapped this to be able to show you what the graft complex looks like. Today would definitely not do that. And ultimately, implant placement, as you're seeing here. And once again, a 10-year follow-up, very predictable. And moving along to a more involved case. As you see here now, we've got significant pathology associated with these molars. Both second and first molars, yes. And in removing these teeth, we know what we have in store. Quite a bit of granulation tissue that has to be removed in its entirety, certainly. Aggressive curettage, both tactily with curettes and even manually with an 8 round burr to make sure we clean these sockets out very carefully. And in this particular case, the grafted site is done in preparation for, as you're going to see, a sinus graft that will follow. So typically these kinds of cases will stage, and making sure we explain to our patient that there are 2 grafts that would be done. One of them I'll call from the bottom up, which means literally grafting the socket to preserve and maintain, if you will, the alveolar bone that we've got. So in this case, 7 millimeters in the left image, number 2 site, and number 3 site, roughly 5.8, almost 6 millimeters. So as I explained to the patient, then at this 4-month mark, we now can have the option of placing these implants at the same time as we graft. And again, this is quite an older case, about 12, 13 years old. And back in that day before, was really working with the ossification burrs and doing these. In this instance, I would most likely be doing crestal grafting today, crestal sinus grafting. But back in that day, lateral wall, which is not a problem and certainly very predictable. As you're seeing before and after here at 6 months, this is, again, one of the most predictable kinds of grafts that we do in addition to socket, i.e. lateral wall, as well as crestal sinus grafting. And there's a 5-year follow-up. And then looking at a case like this, where we've got significant pathology here, failing maxillary molars, fully pneumatized sinuses for the most part. The challenge here always is to be able to extract these teeth in such a way that ideally we don't perforate the membranes, however, the sinus membranes, however, not always the case. But what I'm showing you here is nothing more than intracellular incisions, full flap reflection of our facial flap, and then ultimately the same on the lingual. And now it's a matter of sectioning these teeth, keeping in mind the proximity of the roots to the sinus floor in particular. And as you're going to see here, that, you know, as much as I tried, that we've got some perforations, and that will happen. And typically I will take some collagen, as you're seeing now in the middle images and the right-hand side image, and just more or less layer that over the perforated sites. And then I'm able to graft over that. Of course, not putting a lot of pressure, call it more of a moderate condensation as I introduce the graft, as you're going to see. But there's a before and after, really pretty graphic to see the perforation, certainly. And one would think, well, maybe I can't really graft now. I should just close it up and call it a day. But no, not really. I can certainly use those collagen sponges, certainly in that context, as I'm showing you here. Now, introducing the 12 by 30 cytoplasm membrane, I was really after the folks at Osteogenics, in particular with Shane, and saying, hey, really the 24 doesn't work so well with a number of our maxillary and even mandibular molar cases where that lingual facial palatal distance is significantly longer than we'd like it to be. So therefore, what I'm saying is I would take a 12 by 24 sometimes on either side and then just bring it up, overlap in the middle, and then suture over that, because there just wasn't enough length to really get into the sulc, into the pouches. I typically like about 4 or 5 millimeters of membrane in the pouch. So I was very pleased that the response was, well, let's try some out. So I did a little beta testing on a few. I suggested 30 millimeters. And after a year of playing with these membranes, the word was sure they work extremely well. And I've been extremely happy. So I use the 12 by 30 for most all of my molar cases. And here you're seeing one in each site, number 2 and number 3 sites, certainly. And the graft complex has been introduced, as we've talked about. And then our membranes being placed over, as you're seeing, into the opposite pouches. And by the way, when I talked about the GEM 21, I use that only when I have a facial plate compromise. In cases where we have plates intact and or maybe just a couple, 3 millimeters of bone loss, I don't bother to use that particular protein. But anything more than that, it really is a go-to protein that serves to give a very nice predictable result in terms of bone regeneration when we're typically missing a facial plate. So back to this case, again, 2 membranes used and our typical suturing, as we talked about, again, this horizontal mattress suturing, some interrupted sutures, and then an 8-month follow-up. As we're seeing, we've got now roughly 4.5 millimeters of bone in each site. So yes, we preserved some bone and we can go ahead and place implants with sinus grafting at the same time. In this particular instance, this patient, one of our snowbirds, had taken off for the summer and will be returning for implant placement with sinus grafting. And then turning to a case like this, where significant bone loss with this particular maxillary molar, as you can see, plates compromised on both sides. And once again, for me, when I have a case like this, one of the few instances, few applications that we really need something, I think, more potent in terms of osteogenic capacity, compromise of a site, I like to use BMP here as well. The very small XX size, 0.7 cc's of protein, mixing it with our graft, again, straight mineralized allograft, membrane placement and suturing in site there. There's a 7-month follow-up. This patient actually really wasn't able to come back at the 1-month mark. So the membrane stayed intact. You can see a little pouch was created when I pulled out the remnant, the last segment, vestige, if you will, of the membrane. But look at the histology at 7 months, very predictable, taking a small core. And once again, we see a very good bone regeneration within the socket again, as predicted, I should say, very predictable results. And once again, able to place our implant. There's a 10-year follow-up, good marginal bone stability once again. So proof of concept that we can certainly work with BMP in these sockets. But the best part of it all is that having these membranes that we can utilize in place. And as I went through this case, I know not a lot of time here to get into a ton of detail, but if I just back up for a bit here and just show you that, in fact, I did not flap this case at all. Okay, just tuck the membrane on both sides. It's amazing what an intact socket can do. So this is truly a flapless, minimally invasive approach. And once again, getting a very predictable result as we see here. So that's that molar that had failed. And in the same patient coming back now, approximately a year or two later with a fractured molar next door, first molar. So go figure. We removed these roots, and I was able to graft this site more conventionally with just straightforward mineralized cortical cancellous bone. And then at the 4-month mark, be able to place our implant in a very predictable mode, as you're seeing here. So next door, we have the one site that was significantly compromised using BMP, and then the first molar site, just conventional grafting without any protein. And there's a 5 and a 10-year follow-up respectively. In other words, at the 10-year mark of number 15, that was the 5-year mark for 14. So it was roughly 5 years out that separated these two particular sites that we grafted. And then moving along to just still another type of case that we will typically see where we've got failing maxillary molars, and in particular, one that we're seeing here. And many times when I decornate, I will just literally drill through the roots themselves and then ultimately remove the root fragments, as we're seeing here, and just being able to show very predictably the membrane. And I think that's what's so impressive, being able to use, in particular, these osteodensification burrs in a very nice counterclockwise mode. They do not tear the membrane. So we've got a bird's eye view of this particular membrane, implant placement here, immediate with grafting, a little bit different variation. Certainly we have the ability to stabilize the implant, which makes all the difference for, of course, immediate placement. And that's really what it's all about with regard to our primary objective when we take teeth out. But once again, not always can we get stability, so therefore we're going to graft our cases. But here, I'm just showing you an immediate placement case with grafting and some customized, at that time when I was using basically custom abutments, and then ultimately fabrication of the abutment crown complex, the final one at 5-year follow-up. So again, these kinds of cases we can certainly do with immediate placement. And then it brings us finally to really the type of case that we'll do time to time when I have, honestly, a situation where basically we've got a number of teeth that we're taking out, not so much one. And in these situations, I really like to zero in on using the dentin grinder. It's been about 8-9 years that I've worked with this particular technology. It's kind of interesting, meaning we're able to use the patient's own tooth or teeth in order to graft, use it, and I've used the tooth, the enamel dentin complex, as a graft complex for the sockets. And it's a very interesting protocol where start to finish, we're looking at about 8 minutes of time, not a lot of time. So from the time that tooth is extracted, cleaned, and when I mean clean, any amalgams, any restorations at all would definitely be removed from the teeth. And now, for example, if a root canal tooth got a percha, would not be worth even trying to remove that material. But any restorations, once they're removed and cleaned up, then the implant, or the tooth rather, goes through a disinfection, more or less a protocol, and then could be ground down and used as graft material. So the entire workflow is about 8 minutes. And I use this particular protocol for multiple extraction sites only, not so much a single, because quite honestly, a single tooth can be extracted, of course, and grafted with membrane in a very short period of time. So really would not be wanting to wait just on even an 8-minute time frame for this to turn over from the time the tooth is taken out, for example. So how predictable is this protocol? Well, our good friend and colleague, Shazana Pol, and from Croatia, or a maxillofacial surgeon, did a very nice study on this particular technology, and just beautiful, well done, a 58 extraction socket series of patients, and up to roughly 2 millimeters of missing buccal bone. And what she did was attempting to show that utilizing the dentin particulate autograft along with PRF can result in very dimensionally stable facial plates in general. In fact, overall dimensional stability of the entire alveolar process. And she showed that quite dramatically, and proof of concept that yes, these grafted sites maintain themselves nicely in terms of the overall alveolar process. That's been my experience over these 8-9 years that I've used this particular protocol. So just a quick example as we close out our segment here, and showing you that multiple teeth can be extracted as I'm showing you here. And in essence, teeth that, again, don't have large restorations and or root canal treatment, we can nicely clean and prepare. As I mentioned to you, there's a series of a dental cleanser and then a buffer solution that is included in a small disposable kit. And this is the middle image on the bottom, shows that small disposable canister, so to speak. And it's a 3-second grind to start, and the tooth is literally, or teeth are ground down quite well in that 3 seconds. And then a roughly 20-second, more moderate grind that's less invasive in terms of sound. I will tell you that 3-second one is very loud. The second one is not so loud. But what you see then in that series on the bottom images is a fine granular complex. There's 2 different trays that are used. In other words, as containers for the particular graft collection. And the range is anywhere from 300 to 1200 microns. And then that's mixed with PRF exudate. And I've used bloodborne bioactive modifiers now for some, 27 years. 1998, I believe, was the first year I used a PRF, or I beg your pardon, PRP. And then PRGF was the second bloodborne bioactive modifier I utilized. And then finally in 2012, I believe, I began using PRF, which is a second generation, as we know, bloodborne bioactive modifier. So here just showing a combination of the exudate mixed with the dentin complex introduced into the sockets. And by the way, as few as maybe 4 teeth, all that's needed to graft an entire arch. So something to think about when you have multiple teeth to graft, multiple sockets to graft. And then PRF membranes over that, and then primary closure, as you're seeing here. This patient happened to have a large torus that was removed at the same time. But in essence, what we're showing is a, now radiographically, at 7-month follow-up, what the alveolar ridge looks like. And I will say this, I wait 1 extra month. In other words, a 4-month time frame would become 5, and a 5-month time frame would become 6 if I'm looking at grafting with autogenous dentin, as you're seeing here. So in essence, what I really want to emphasize is the conventional socket grafting that I shared with you early on, both maxilla and mandible, with minimal, if any, alveolar plate compromise, more or less an intact socket in terms of plate compromise, then the reentry is 4 months. If in fact the plate is compromised more than 3 millimeters or so, then I wait an extra month and add the recombinant PDGF to the complex. So that's really the formulation in a nutshell that I like to look at for these particular sites. And I think that's important to note the difference in terms of timing. How predictable are these grafts? Well, I'll tell you, of all the grafts that I've done over my career, no question, socket grafting ranks right up there, number 1, followed closely by certainly sinus grafting, both lateral wall and the crestal approach that I've used in the last 8 years now. So in summary, basically what we're talking about is we have a series of sites that we can look at in a most predictable mode. So really, to sum things up, socket grafting, as I've shared with you, with mineralized coracocancellous bone and these PTFE membranes, allows for a very predictable alveolar ridge preservation, no question. The sun comes up, the sun goes down. We're talking a time frame of 4 months on average that we can predictably know that we're going to have adequate bone volume and density in order to place an implant and place it with immediate temporization if we so desired, certainly with custom healing abutments, etc., but knowing that we have good insertion torques as if we're in virgin bone. So this has been a time-proven protocol that I'm sharing with you that has changed very minimally over the years, only because these membranes have been available so long that I really embraced their usage, and not just for sockets, but certainly for alveolar ridge deformities in general. But for sockets, this particular single implant, or single as it's called, 12 by 24, as well as a 12 by 30, has really been my go-to set of membranes that I utilize for socket grafting. In addition to mineralized corticocancellous bone, that has been my go-to graft complex for some 25 plus years, having used demineralized bone before that. And then certainly what we see at 4 months is a D2 quality bone, as evidenced by numerous cores that I've taken over the years. And we know that reentry is so predictable with regard to bone density that, again, these implants can be placed in a very predictable mode. And certainly immediate implant placement into the sockets is very predictable, as I've mentioned already. So talk about a predictable graft protocol from start to finish. There's really no reason to deter from this particular protocol, as I've just shared with you, giving you just a quick overview of what I cover in a whole lot more detail, and certainly our number of our different courses here at the Institute. But I think what I enjoy doing the most in terms of predictability, once again, is these types of grafts that allow us to place an implant very predictably once we've grafted that site, knowing full well what we're going to get. There's no guesswork upon reentry. So with that said, the pride and joy for both my wife and I these last 7+ years is having 6 amazing grandchildren, 5 little girls and a little boy, so that each of our children has 3 kids. Left image are the 3 kids of our daughter, Lindsay. That's little Ella, Andy, and Olivia. They're 7.5, 5.5, and now 3 years of age. And then the right-hand side are the 3 little girls that my son has, and I'm holding little Nora. My wife is holding Margot, and then the little insert on the right is our newest addition to the family, and that's little Kelly, and she's just 3 months old. So I can tell you that as a grandparent, that's a very special dynamic, and again, I've enjoyed having them close to us. So that has been just a real plus. So things to do outside of dentistry, certainly family is super important always, and we can't overlook that most important item of our life. So with that said, again, I would like to thank both Shane, Russ, and certainly Shelley for this opportunity to be able to participate in this particular webinar with you. I know I can't see you, all of you that are out there, but I just know that I'm at your fingertips in terms of being able to help you anytime via either email, texting, whatever. But the Institute now, again, in its 36th year, I've enjoyed immensely being both an educator and a clinician, and still doing these things full time. I thoroughly enjoy what I do. My work really has been kind of my play, so to speak. So it's never really been work. I've enjoyed the opportunity to interface with so many great clinicians over the years, and look forward to seeing a number of you at different meetings ongoing, et cetera. I know with our time remaining, we certainly can entertain some questions. So I do believe Shelley's going to be giving Russ some questions, and I'll be happy to entertain them for our time remaining. Thank you all so very much.
Thank you, Dr. Pikos. Great information. Appreciate you sharing with us. And we do have some questions. So start with the first one that came in here. Do you have any advice, or could you describe proper socket debridement, especially if there's an infection present? Do you use a curette or a round burr? Is the end point known when you can see all the socket walls clean and no remaining tissue clinging to them? I think generally what's your how would you describe properly debriding a socket, especially one that might have some infection present?
Sure, it's a great question and a very important one, because in this whole workflow, that is a very critical part that we have to really pay attention to. And let's face it, we all tend to get in a hurry sometimes and want to just kind of get the case over with. But I will tell you, if there's a rate limiting step, that would be the one. Once a tooth is removed, roots are removed, and we're thinking that we're done, you've got to just tell yourself, I'm not done yet, no matter how thoroughly you've done your debridement, et cetera. I use two different curettes, dental alveolar curettes. The larger one, it's about 3.5 millimeters in width. I do use for the socket, but primarily for that pouch formation. Again, hugging bone the way it's angled, I'm able to get right against bone and create that true subperiosteal pouch. The smaller curette, which is about 1.5 millimeters roughly in width, that's the one I use primarily for going after the apices of the sockets, because then you only there do you really know that you have been able to clean the sockets carefully. In other words, good tactile feedback certainly. Also, 8 round I'll use very typically for that socket in order to get good bleeding bone, but also to make sure visually and tactily I'm seeing everything I need to and feeling everything I need to. And then, especially in your blind spot areas, it's not unusual to leave some granulation tissue and not realize it. So thorough debridement, take your time there. And again, it's a combination of curettes and I use an 8 round rotary drill. Yes.
Great. A couple questions regarding the sinus complications that you showed. I think you can answer them both in one answer. But what size exposure or perforation would necessitate that procedure other than placing a collagen plug at the base of the socket? That's A. B, when you are dealing with that complication with this collagen plug, are you sticking the collagen plug up into the sinus, or is it just resting at the base of the socket?
Okay, let me take the second part first, because what I showed was some perforations, maybe a couple, 3 millimeters overall in dimension, with height, or width and length rather. So those can be fairly conveniently grafted, or I should say covered, with that collagen membrane to speak of. So like a small blanket over the entire membrane that's left, and then grafting over that predictably. Now, a contraindication to that protocol would be complete perforation. So let's say, for sake of discussion, that second and third molar case I showed, or first and second molar case I showed, let's say I perf completely. Well, then there's no grafting to be done. I would then typically take the buccal fat pad and just pedicle it down and cover that entire socket and get closure over that in that fashion. So in other words, I would not be grafting that. That would be a delayed re-entry, where then I would, after 4 months of healing, would just do a conventional lateral wall approach, because that would be more or less a fully pneumatized sinus. So a little different protocol there. So keep in mind that, I'm more or less promoting and suggesting that for the smaller perfs like I just showed you with that case, those can be covered predictably with just a collagen plug, flattened, knowing that it won't last that long, but long enough to form a coagulum and maintain the graft so it doesn't extravasate into the sinus.
Great. Quick question on suture. Just in the posterior, when a routine posterior extraction with a membrane, like you described, can you just reiterate what suture you're using? The question says, can we use chromic gut, or can we use PGA 3.0 or 4.0?
Basically, any suture can be used, really, but my preference is, for the longest time, I've used PTFE sutures, and I still do, depending on the specifics of the case. But I will say this, that nylon works quite well, because at the 4-week mark, In other words, if you're waiting 4 weeks to remove the sutures, which I recommend you do simultaneous with the membrane. In other words, what I did for a number of years, I would see the patient at 2 weeks, remove sutures, at 4 weeks, remove the membrane. Then I realized that, wait a minute, why not just do everything at once, save the patient an appointment, save me the time. So I'm forgetting how long it's been, a good 7, 8 years ago, roughly, I decided let's just wait 4 weeks. So if you wait 4 weeks with PTFE suture material, it tends to attract plaque and not look so great. So nylon is not a bad way to go in those cases. In particular, glycolon could be used, which is a resorbable nylon. So if in fact for any reason the patient would have to be not seen, let's say even at 4 weeks, then that's not such a bad suture material to use either. But even chromic gut could be used also. It's just that waiting a full 4 weeks on that may not be such a good idea in terms of having that suture break down. So we don't want any premature exposure of our graft complex, certainly. So my vote would be, if you're taking sutures out at 2 weeks, PTFE suture with the large FS2 needle is fine. And perhaps even 4 weeks if you're not so concerned about the plaque buildup. But nylon is not a bad way to go either. But I think regardless of what suture material you're using, what I do want to emphasize is the way I did that crisscross suture mattress. In other words, I could just go with 2 swipes on both the facial and the pellet, and that's a quick crisscross, but it's going over the tissue margins, right? It's not adapting directly to the membrane. What I did show there, and in fact, maybe we can go back to that second case. I would say let's try slide 40, and I can then go from there. I don't remember the exact slide. It would be, that's not bad. Perfect. Thank you. So let me now advance and go right to suturing. Here we go. Oops. So let's start right here. Okay, we tuck the other membrane, other side of the membrane in. So now I'm coming out from the facial. So I'll call this outside in. This is mesial buccal, right? And then I'm going to go distal lingual, inside out. And then I'm going to come, so that's the distal lingual. All right, so then the next slide, I'll show this image. Now I'm coming on the mesial lingual, outside in, and then inside out on the distal buccal. So it's a crisscross horizontal mattress, but see the sutures are directly on the membrane. And then of course it's tied here on the facial where we started. So I want to make sure everybody's understanding that it's directly on the membrane. If I just did 2 swipes, it's very easy. This one this way and one this way, and tie it. That's a crisscross horizontal mattress, but it comes over these flat margins, right? In other words, I'm not directly on the membrane. There's a big difference. This membrane really cannot move once I've done this, and then add to that 2 single interrupted sutures, one here, one here. That's it. And at 4 weeks, we remove sutures, remove the membrane, and once again, under that membrane, you'll see a very nice coagulum that's early reepithelialization, and then ultimately at 4 months, it will be completely keratinized. So I hope that maybe clarifies the suturing techniques I use, I've done for years, works the best. Now, the 2 swipes that I just mentioned earlier, I will use that only when I have a large connective tissue graft, for example, that I'm placing, especially in the aesthetic zone, and I'm suturing over that complex. Then it's a different kind of light compression over the graft. That's different. This, I want direct compression on the membrane. So I hope I made that a little bit clear. I know I didn't have a lot of time to go through it in my regular presentation here. But also one other important point, and that is right here, when placing these membranes, okay, I'm suggesting that you create a real good pouch like this, where you can see, all right, between periosteum and bone. If you can't see that, the membrane is not going to slip in there. It should slip in there very passively. If you have to fight it, it's going to crimp, it's going to fold up, and you're going to have to pitch it and start over. And that's not a lot of fun. So what I'm suggesting you do once you've trimmed your membrane, et cetera, is create that kind of a pouch and then slip the membrane directly into it. And it's really straightforward.
It leads right into the next question. I was just going to ask, while we have this picture up, the next question I was going to ask that came in is, how many millimeters buccally and lingually are you tucking the membrane? And what instrument, what instrument, I know it's easier said than done. What instrument do you use when you're doing that?
Yeah, believe it or not, I like to use pickups with teeth. I'm holding, in fact, I'm showing it right here. I'm holding the flap, okay? And how do I work this down? I just take that dental ability curette and just work it straight down into the pouch. Sometimes I'll take a Quinn elevator and work it down also. And you're able to move it passively into that pouch, is assuming you have completely detached that periosteum, in other words, created a real good pouch that you can visually see the gap. If you can't see that gap, that membrane is not going to make it. It has no real integrity to it to speak of, so therefore it's going to crimp. And once it crimps a few times, it's gone. It's shot, and you start over. So that's an important little pearl on placing. You've got to be patient, but there's a method to the madness, very predictable. And these cases are done very quickly. I mean, 20, 25 minutes or so, we're done. And I call these annuities because they're coming back in 4 months and you're placing that implant. So you've just, half an hour of time for the extraction graft membrane and that same amount of time or less for the implant. I mean, it's one of the most important, rather impressive things we do in terms of an ROI in all of implant dentistry, period.
How far are you estimating? Just you say 3 to 5 millimeters, 1 to 2 millimeters.
Far? Approximately 4 or 5 millimeters on each side. Yes, and that's why the 30 millimeter is great for these large molars that we take out, especially in the maxilla. We got a big span, so 30 millimeters is really nice to be able to get a good 5 or so millimeters on either side and span that gap. So 5. Roughly plus minus is what I'm after.
Fantastic. Well, I think that's a good place to end, and we're 10 seconds until we're out of time. So perfect timing. Once again, Dr. Pikos, just want to thank you for doing this for Osteogenics and better yet for the colleagues on the call. Really appreciate your time. Last thing, I just want to remind the audience that you will be getting a email with a survey, feedback survey to your email shortly after we end the call here. Once you fill out that survey, that will trigger us to send you your CE certificate. So please be on the lookout for that. With that, thanks again, Dr. Pikos.
Thank you, Russ, and thank you to all of our attendees.